evening. I, Nitin Modi from Nishiro Pharma, request to Dr. Kaveri Madam to start. We are online, Madam.
Good evening, one and all. First of all, Happy New Year to all who has joined here with Jabalpur OBGY Society. We appreciate your concern that change in the life and change in surgical field, we all are ready to accept. And of course, from opening abdomen to keyhole surgery, it's really a challenging thing for each and every surgeon. But once we are master in it, we really start loving all these keyhole surgeries. And of course, learning is always depend how you want to go ahead with it. A person who is ready to learn even in his 80s is always a person who can accept any challenge. And a person who is not learning, who is not interested, even in 20s, the person is old by heart. So I hope we all young people with learning attitude are very, very happy to join this hysteroscopy and laparoscopy basics webinars, web series with endoscopy committee, which we have requested Dr. B. Ramesh sir to go ahead with it, and he really accepted the request, and we planned this web series for all beginners and all masters as well, because perfection is always expected, and you can learn when you can see what you are actually doing. If you don't able to see your faults, you will never able to change your mistakes. I thank to Medical Education Committee, Chairperson Dr. Abha Singh Madam, who has taken this web series into account and gave consent to join it with endoscopy committee and with Jabalpur Society, because as President Dr. Anuradha Dang Madam, she has a vision that each and every PG student as well should be a master in keyhole surgeries, because the era has come when we have shifted to robotics, and we need to understand the space environment, space anatomy, and before entering that, we should know how it is seen from a whole. Without taking much time, I really welcome all my chief guest, Dr. Abha Singh Madam, and Dr. B. Ramesh sir, for taking in account and giving us this opportunity. We could able to make this web series start from today onwards, and I hope all who are there, they will definitely expand this message. They will definitely spread this message to their colleagues as well, so that no. Now I hand over the program to Dr. Anuradha Dang Madam. Madam, kindly proceed with it.
Thank you, Kaveri, and good evening, everybody. My special thanks, and I welcome all these seniors and my colleagues of Jabalpur Obstetric and
लैपटॉप पे कनेक्ट कर देना बेटा.
Yes, we have some.
वही रखा कमरे में.
Yeah, good evening, and I welcome all the seniors and colleagues of Jabalpur Obstetric and Gynec Society and all the other members who have logged in with us today for this web series on keyhole surgeries. I'll just take a moment because the voice is echoing.
I hope you have not
As
got
we've seen in the COVID times,
devices.
life
Two
is
devices
ruthless,
open.
but still we have to keep patient and move on. We have to be innovative to overcome the hurdles. Science is an art to explore oneself and to keep innovating the methods to help the mankind. With this constant perseverance, the keyhole surgeries and the minimal access surgeries are in the market these days and they're at the boom. So we wish that all our PGs and all our members are updated with the latest knowledge. And I sincerely thank the endoscopy committee, Dr. Ramesh sir, and the chairperson for medical education committee, Ava Singh madam, to constantly guide us how to go about this program. Thank you so much, madam. And I welcome all. I also take the opportunity to welcome all my chairpersons who have already logged in with us. The guest of honor for today is Dr. Mandakini Meg, madam, but she had already informed us that she's in a very important meeting and she will join us as soon as it is possible for her. The chief guest for today's program is Dr. Abha Singh, madam. She's the director and professor and unit head of the Department of OBGYN, Lady Harding Medical College, Delhi. She's been the ex-president of Delhi OBGYN Society, and madam has been at various responsible posts in the FOXI all her life. She has been the chairperson of DSC, PCP and DT committee, chairperson of Safe Motherhood Committee, and madam has delivered guest lectures, moderated various panels, and taken part in various panel discussions at national and international levels. Madam has also contributed to the guidelines published by Government of India. So it is a great honor for Jabalpur Society to have Dr. Abha Singh amongst us today. Thank you so much, madam. We wish to hear a few words of blessing for our society from you, madam.
Thank you, Dr. Anuradha and Dr. Kaveri for inviting me for this laparoscopy and endoscopy committee. And good evening, all the delegates and all the speakers. So during this COVID times, we are having a real difficulty in seeing the patients and teaching our postgraduates. Our postgraduates should know to see the patients, that is clinical examination, as well as diagnose carcinoma, cervical carcinoma in the early stages. What happens? A number of deaths, 70,000 deaths occur per year, and around so we have to literally reduce the rate of these cancer patients, cervical cancers. Another thing is they should be detected early in the really early stages so that management and treatment is possible. So this colposcopy and another thing is you should know the colposcopy. First thing is screening, and then you have to go in keyhole surgery, like doing a hysteroscopy. So hysteroscopy, if the patient has come with postmenopausal stage, then you should be able to do a hysteroscopy and see whether this patient is having any growth and take a focused biopsy from that area. Earlier, we used to do a dilatation and curettage to pick up the endometrial tissue. And if the endometrial tissue showed evidence of malignancy, we had to curate all the walls. But nowadays, hysteroscopy is available. A hysteroscope is put inside the uterus, and you can pick up tissue from the small area. So that is possible these days by doing a hysteroscopy. Then we should know how to do the laparotomy. I know that it is really essential. You should know the steps. And if there's any problem when you're doing endoscopy, you should not shy away from doing a laparotomy. But in laparoscopy, you get a magnified view. So it is good for the patients as well as for the doctors. The time initially will be more, but later on, as you go up the ladder, the time for doing this surgeries will be reduced. And another thing is that the blood loss is less for the patient, the pain is less, and to stay in the hospital stay admission time is also reduced, and patient can go back to work as early as possible. So you can take the patient for a laparoscopy, but the basic step of laparoscopy should be known, and if there is any complication, the laparotomy also. So that is essential. And in these COVID times, it is really difficult to teach on the patients, and you may not have not got the opportunity. So many patients in these times. Taken by Jabalpur Society, train the postgraduate students, and I hope you will be interested in learning, and whatever doubts are there, you can ask the questions. You should put the question in the chat box, and the answers, you will get the answers. So I congratulate Dr. Anuradha for taking this endoscopy, or you can say keyhole surgeries, to the postgraduate students. Thank you, and I wish you all a success.
Thank you, madam. Thank you so much for those kind words. Now I'll request Dr. Kaveri to start the first session.
Our first session today is on indication, instrumentation, and contraindication. And for this, I would like to call our chairperson, Dr. Pragya Dhiravani, madam.
Hello. Am I audible? Am I audible?
Yes, ma'am.
Yes, madam.
So
Dr.
good
Pragya
evening.
Dhiravani, madam.
Madam,
Ma'am, I just want to brief out just your short introduction to the eminent
Very,
faculty.
you have to be very short, very short.
Very short, very short. She is one of the dynamic lady in Jabalpur, and she is our past president, and now recently she has joined as a Indian Jabalpur Menopause Society presidentship just last week itself, and we are really blessed that such a cheerful and active lady is always with us and to guide us in our society. Without taking much time, I just hand over to you, ma'am. And of course, she has many awards. I'm not going in detail, but
Don't.
No sound.
yes, ma'am.
No sound. Now audible.
Now it's audible.
Ma'am, audible?
Now it's audible.
Yes,
Yeah.
yes.
Hello.
Now.
Yes.
Okay, okay. I think connection got lost in between.
Yeah.
Yeah. I was just introducing the eminent personality in Jabalpur society.
There is some connection problem, Kaveri.
Now, madam, you are audible.
Now she's audible.
Hello.
Okay, go ahead.
Kaveri, can you please share the CV, the screen share? CV of Dr. Rajesh Bhatta. Hello. Good evening, one and all. Am I audible, madam?
Yes, ma'am, you are audible.
Pragya, you are audible, but the screen is not visible for
Yeah,
us.
yeah.
Hmm.
Meanwhile, Kaveri, can you please share the screen and CV of Dr. Rajesh Bhatta? So good evening, one and all. And it is our, at this outset, I'd like to thank Nishiro and Endoscopic Society and Jabalpur OBGY Society for giving me this opportunity to chair this session. And in present era, as rightly said by the Kaveri, learning and progress is directly proportional. As soon as we stop learning, our progress will automatically stop. So hysteroscopy is the gold standard in the diagnosis and treatment of intrauterine lesion, and hysteroscopy revolutionized and changed the face of endoscopic and minimally invasive surgery in gynecology, and as well as that in the treatment of infertility also. So in this era, every person should know how to do hysteroscopy properly, correctly, and give benefit to the patient. So to begin with the first session, the lecture delivered by the first session, the speaker is Dr. Rajesh Bhatta. He is consultant of Roshni Laparoscopic and Infertility Center, Udupi. He is associate professor from 2000 to 2012 in the Kasturba Medical College, Manipal. There are so many awards in his credit, like Shan S. Rustam Young Gynecologic Award in the year 2006 to 2007, the Jogi Arch Rustam Irani Prize for the year 2007-2008 for the study on a randomized control study to evaluate the cost, effectiveness in sperm extraction using carbon dioxide and carbon dioxide free system in IUA program. This award he received in AICOG held at Delhi in year 2008. Foxy VHB Award during the 50th AICOG in January 2006 at Kolkata, West Bengal. He is awarded as a best scientific paper at Karnataka Obstetric and Gynecological Association conference held at JNMC Belgaum on 28th and 30th September 2001. He is also awarded by Foxy Contact Device Award for Young Gynecological Award in 1997 during the 41st AICOG, which was held in Siliguri, West Bengal, India. And he has been awarded by a prestigious Dr. C.L. Zaveri Prize for Best Paper Presentation titled Silent Bacterial Infection of Semen, a Cause of Male Infertility during the 41st AICOG in December 1997 held at Siliguri, West Bengal, India. He has many publications and presentations in national and international journal and presented many lectures in national and international conferences. His area of special interest is in gynecological endoscopy and reproductive medicine. Topic of today is
light
indication, instrumentation, and contraindications of hysteroscopy. Welcome, Dr. Rajesh Bhatta, and over to you, sir.
Thank you very much, Dr. Pragya. Before that, can I share my screen? Is my screen visible?
Yes, visible, sir. Visible, sir. It's visible, sir.
Thank you very much, Dr. Pragya, for a very nice introduction. First of all, I'll take this opportunity to thank our Foxy Endoscopic Committee, Dr. Ramesh, Foxy Education, Medical Education Committee, Dr. Abbas Singh, and all the team member from Jabalpur Society headed by Dr. Anuradha and Dr. Kaveri Shah. So I bring greetings from the temple town that is Udupi. The topic today, which has been given to me, is on indication, instrumentation, and contraindication on the series of keyhole surgery topics. Out of the one, today is the basics in hysteroscopy. Uh, it has been just now re-updated by the secretary of Jabalpur, and this might be a very apt thing to know that uh, the illiterate of the 21st century is not the one or who know to read or who cannot read, but it is important to those who cannot learn, unlearn, or relearn. So this is a very, very, very important thing which we all have to go through so that we learn, we unlearn, and we relearn. And this also holds very good when we're looking at an hysteroscopic, and there's so many technical and technological advances which we have seen since last 2 or 3 decades, and we have seen in our own life what changes we have seen in the last 2 or 3 decades, and the same thing which we are seeing in the present era in the field of hysteroscopy. We all know that in 1980s how an hysteroscopy was done and how things have revolutionized. In 1980s, the revolutionary endoscopy, video endoscopy had taken place from putting a small chip into the camera, making us seeing the inside of the uterus so beautifully. Then came Ms. Bertocci, Dr. Bertocci, who revolutionized this modern hysteroscopy by introducing what is called as office-based hysteroscopy. The first operative office-based hysteroscopy occurred in the year 1995 to 2000. Then the incorporation of monopolar and bipolar energy was constructed, and now with so much advancement, we are now into an era where we are doing hysteroscopic modulation since last about a decade now. So the diagnostic hysteroscopy, which not only used for diagnosing the intrauterine lesions like polyps, myomas, or looking at the additions, but also it helps in correcting these pathologies which is seen inside. And all are aimed at a common goal is to remove the pathological change what we see inside the endometrial cavity. Now, the changes which we have seen in instrumentation in the hysteroscopy and also with the technique and a proper evaluation has changed our management, and looking at the endometrial cavity itself has changed so much. What we were using a 4 millimeter and above hysteroscope, and now we have a mini hysteroscopes with an operative sheath including all inclusive less than 5 mm, and this has made a big change in management of or correction or doing approaching hysteroscopy in our day-to-day gynecological practice. What you see here, a picture, is a picture of a mini hysteroscope. You can see that the hysteroscope, which is less than 3 millimeter, and we have a sheath an outer sheath and an inner sheath with the operating channel, all put together less than 4 millimeter. We call it as a mini hysteroscope. And also the change in the shape of the scope from round to oval, all these have made into a lot of changes which we see in the recent time hysteroscopy. You can see here the hysteroscope in the palm, where it's such a simple instrument where we can just use this for a diagnosis in the office setting. So, so much has been the change which we have seen in the last 2 or 3 decades. Now, when we talk about the indications for doing diagnostic hysteroscopy, so where we are using this hysteroscopy, the most one of the common condition where we do is uh, uh, do hysteroscopy is to evaluate in a patient with abnormal uterine bleeding, either premenopausal women or in the postmenopausal women, or in patients with a postmenopausal endometrial thickening with a negative endometrial biopsy, or in situation to evaluate infertile patients, can be because of a polyp or maybe a fibroid or maybe a septum, and so many several other indications where we can use not only for diagnosis but also for treating these conditions. Use hysteroscopy in locating a missing foreign body or like intrauterine device, or in a patients with the retained products, so that we can not only diagnose, we also can be used for therapeutic. Other indications like evaluation in a patient with recurrent miscarriage, or when an abnormal transvaginal ultrasound showing some intrauterine pathology, or an hysterosalpingogram showing either a corneal block or any space occupying lesion inside the uterine cavity, or in patients with preoperative evaluation or postoperative evaluation. There are many other indications which I could not highlight, but there are many others like in evaluating the scar in a patient with a previous cesarean, or a detection of isthmosele, or many other situations where we use hysteroscopy for diagnosing as well as in treating in patients with either a patient with infertility, where we use that as very common, or any other gynecological conditions. Now, as we have seen in the last 3 decades, how an inpatient hysteroscopy where we used to do has changed from an inpatient to daycare, and now what we are talking is an outpatient. All this is because of usage of a newer, smaller diameter hysteroscopes, which has allowed us to do these procedures with a very minimal pain to the patient. Not only that, the, the acceptance by the patient towards this has enabled us to perform many diagnostic outpatient hysteroscopy to treat the uterine lesions. So, hysteroscopy in an office setting allowed most of the clinicians for us to see and treat policy, so that it becomes easier and to treat, and also with a better acceptance by the patient because of newer technique and newer instrumentation. The newer vaginoscopic approach in outpatient hysteroscopy has also remarkably changed our way of doing hysteroscopy, where we don't use any speculum, we don't use holding the cervix by valsalem, nor we do any dilatation of the cervix. We just use this cystoscope to enter inside the cervical canal and the uterine cavity without any touching any of these muscle fibers, which has made the pain to almost negligible. And this method of doing the hysteroscopy has a very high success rate and a high rate of detection of the pathology and a very low morbidity, which has gained very, very high acceptance in the day-to-day practice. So there are many advantages of outpatient hysteroscopy where the anesthesia is not required. So the patient spends very less time of her work, and that has decreased the cost. So acceptance has increased and satisfaction has increased by the patient. And it is one of the important integral part of many of the one-stop clinic, and many of the hysteroscopic procedures like either directed sampling, a small polyp, or a minimal adhesiolysis, or some submucous fibroid which is completely within the endometrial cavity can be removed very easily even in the outpatient settings. So what are the things or what are the instrumentation what we require for doing an hysteroscopy? Now, apart from what we use, camera, the monitor, the light source, what we use for his, laparoscopy, we require the same in addition to the telescope, that is the hysteroscope. We require some hysteroscopic sheath, that is the covering for the telescope, so that there is an inflow channel for passing the fluid across towards the endometrial cavity for the distension of the uterine cavity, so that we can visualize the inside of the uterus. And also for operative procedures we require specialized resectoscopes with operative instruments, so that we can pass this instrument for doing some surgeries inside. So we require, apart from the sheath and the telescope, we also require some things to distend the uterine cavity, and that is what I'm just put it here the picture, the media, that is the saline. There are various distending media which we can use. We started earlier, about many years back, the carbon dioxide as a distending media. And now with the newer saline, and that has improvised our visualization with the low morbidity. So we are using the distending media, the gravity based distending media for distending the uterine cavity. I think there is the next speaker is going to elaborate in a very detail about the usage of this distending media. So here I have shown you the gravity base, and we require in a place where we want to do a longer duration of surgery, we might require a sustained visualization. And to increase the intrauterine pressure, we might have to use some machine, that is the hysteromat, in this situation, so that we can have a good distension of the uterine cavity. And for a trolley set which should have a dilatation and curettage set, it is just in case when there is a difficulty we might require this. So a DNC set normally have one speculum, maybe a valsulum, a sponge holder with a sponge, some dilators are what is the trolley which you should have. So let us go and see. In the operating room, you have operating table with a semi-lithotomy position and a monitor, a camera, and we require some amount of the distending media with the saline, a trolley, and to increase this pressure, we can either use a pressure bag or we can use a hysteromat or a very different way to increase the pressure by this particular simple needle and a BP cuff attached, where we put this needle right into this column of air here with a single prick, and we inflate this BP cuff, increasing the air column, and with this increase of the air column, we push the fluid down and we increase the pressure, which we can get a sustained uterine distension by increasing this pressure. So this is the setup in an operation theater. And this same setup, when you duplicate outside the operation theater, we call this as an outpatient hysteroscopy. So it is not inside the operating theater. This duplication, when we do it in the office setting, is what we call it as office hysteroscopy. So what are the types of hysteroscopes which are available for us for usage? Either a rigid telescope or a flexible telescope. And in the rigid scope, we have various diameters which are available in the market, right from 1 millimeter, 2 millimeter, 2.9, 4, 7, and 10 millimeter. But we don't use anything more than 7 millimeter for hysteroscopy, or maybe not more than 10 nowadays. I mean 4 millimeter nowadays, and mostly we use 7 and 10 for a laparoscopic purpose. And we look at the angulation of the telescope right from 0 degree. We have 12 degrees, 15 degrees, and 30 degrees. And even some of the scopes we have up to 45 and 75. But most often we require an angulated telescope so that the visualization of the lateral aspect of the uterine cavity very easily. So a 30-degree angulation at 4 millimeter and less are very useful in doing hysteroscopy. So in the sheath, we have different sheaths which are available for diagnostic purpose with either a single channel flow or a double channel flow. A single channel flow is only for the inflow of the fluid towards the uterine cavity, and that the outflow is not there. So it's a single flow sheath, or we have two flow where there is an outflow tract also. Now when there is an outflow tract plus the inflow tract, the diameter of the sheath will be slightly increased by 1 mm, and that helps for a better visualization when the fluid circulates very easily. And we have different sheath sizes. The shape of the sheath has revolutionized to from round to oval so that we can easily cross the internal os, as we know that the internal os, which is about 4 to 5 millimeter in size and is oval in shape. So a oval sheath helps to negotiate the internal os very easily with a very decreased pain, so that we can uh, pass the internal loss very easily. And we have resectoscopes ranging from 26 French, that is around 9 millimeter, 8 to 9 millimeter in diameter, to an 18 French, which is about 6 millimeter in diameter. So there are various choices which are available in the market, and more common what we use is a scope which is 4 millimeter and less, with the angulation of at least 30 degrees, with the operative channel for both inflow and outflow, that is the double channel, and ideally between 18 or 22 French hysteroscope. So that is what, for a better sharp view, a 4 mm scope or a rigid scope is a very good for visualization of the uterine cavity. And we have flexible office hysteroscopes which are available, and this also has an operating channel inbuilt, so that it becomes easier for diagnosis as well as and taking some biopsies or doing small surgery inside the uterine cavity. The only important thing is little expensive when compared to a rigid hysteroscope. So we have this hysteroscope with the sheath there, with the inflow and the outflow tract, with the operating channel. So 3 channels in this sheath, and the whole sheath is oval shaped. You can see there the oval shape. You can see here it's an oval thing. So it becomes easier for the negotiation past the internal uterine orifice. So that is the simplest diagnostic hysteroscopic instrument what we have seen now, from a round hysteroscope or round sheath to an oval sheath with 2 operating channels plus 1 operating channel with the 2 outflow sheath, inflow and outflow sheath, which has made our work on hysteroscopic much easier, doing more or going more towards an office-based hysteroscope. So that is what I just wanted to highlight for all the postgraduates, where the hysteroscopes which are available now are thinner hysteroscopes, so it will be a more fragile. So the operating instruments which has to pass through this are more thinner, which is a which is more fragile. So there is more number of breakage which we normally see when compared to an hysteroscopic, laparoscopic instrument. So the hysteroscopes are the regular size around 4 mm hysteroscope. Anything lesser than that with the operating sheath less than 5 mm are called as mini hysteroscopes. Now, it is important for us to understand where it is uh, not only for the usage of outpatient hysteroscope, but also for operating hysteroscope. And also we require to know how to assemble this operate any operating. I'll just show you this particular video. You can put the scope into the sheath here with the lock there to put so that it doesn't slip. So it has got an outflow sheath here and an inflow sheath. The camera is attached to the eyepiece. The light source is attached to the light piece of the telescope, and then there's the operating channel for the inflow of the fluid distending media, where we connect this particular distending media to the inflow, and the outflow is also connected, so that we can measure how much amount of outflow which is there. So once this particular is assembled, we use a simple vaginoscopic approach by putting the scope inside the vagina, putting the distending fluid and distending the vagina first, and we can see the cervix. And once we see the cervix and the external ostia, we slowly enter through the external ostia along the cervical canal. We see the crypts of this cervical canal towards the internal os and to the uh, uterine cavity. So this is how we simply can do the diagnostic hysteroscopy without much difficulty, but requires little bit of practice to do this particular vaginoscopic approach. Otherwise, if any difficulty, you can always hold with by the speculum and the cervix with the valsalum, and then you can pass through this scope inside. So this is the way which you can easily do a diagnostic hysteroscopy. I think the technique of doing hysteroscopy, I think Madam Madhuri will tell in the next session. So let's go ahead. So this is the resectoscope. So you can see here the difference of the resectoscope. It is more wider. Compare, you have an operating channel attached to it, that is a monopolar or a bipolar. This is a monopolar, what I have shown. This is a 26 French, which is the yellow one, which is 26 French, and this the white one here is a 22 French. Now you see here for the operating, there are multiple holes here, so that the flow of the fluid and the back the outflow from the hysteroscope comes from here, then from the fluid around the uterine cavity goes from here back to this outflow tract. So here you require an electrosurgical unit, so that you can connect a monopolar current or a bipolar current depending upon the operative hysteroscope what you have. You have the hand piece here, where you put your thumb here and the two fingers here. So when you press this, you can see that the operative instrument which is attached here comes out of this, so that you can do a simple any surgeries inside the uterine cavity. So just to see the assembly of the operating instrument, operative hysteroscope. So here you have the operating instrument. Here I use just for demonstration purpose a loop, and you pass through this, press this knob so that you can get connected inside that. You pass the scope through this eyepiece. You can see here, you have to align this, otherwise it can move. So you can fit the scope, connect, turn that knob, pass the inner or inner sheath, and you can connect it there, and then finally the outflow sheath which required to be connected. So you have now the three pieces: the outflow, inflow, and the main. So now here they are connecting the energy cable, the camera, the light source, then for distending media, you connect the distending media cable to the inflow tract, and that completes the assembly of the whole instrument. You can see that. And when you press this, you can see the operating instrument which comes out, which helps for cutting. So when we use when we in case of infertility, any patient who any patient who was coming to for the outpatient, the first thing what we do is a simple transvaginal sonography, and maybe for a partner we do a HSA or a semen analysis, and for tubal patency we do first as hysterosalpingography. There is important to know there is no role for hysteroscopy as a routine evaluation, and it should be reserved only in specific condition. So a good transvaginal sonography, you see a good triple line endometrium, there is no evidence of any pathology inside. There is no role for doing an hysteroscopy as a routine. That is what I like to highlight. And many of other simple histogram or a 3D ultrasound offers a less invasive method to detect any pathology. So a routine hysteroscopy is not required. The same thing has been very well said in the RCOG, that a routine hysteroscopy is not part of an initial investigation. So let's come to the problem of polyp. Most of our polyp can be detected by ultrasound by an hyperechoic area seen inside the endometrial cavity, which we can reconfirm by putting some amount of fluid inside the endometrial cavity, where we can delineate the polyp very, very beautifully. And that polyp requires to be removed. And it is important to note that a blind dilatation and curettage should be avoided in this situation rather than a more specific hysteroscopy where we see the polyp and we can treat the polyp by doing a polypectomy in these patients with infertility. Now, polyps required to be removed because it can distort the cavity. It has got some detrimental effect on endometrial receptivity, for which reason it might be one of the cause of infertility. So, it is very well documented that endometrial polyp requires to be removed either before an IUI program or before an IVF program. And this detection is very important. Any abnormal endometrium, like a thick endometrium, a cystic endometrium, or a very thin endometrium, all you have suspicious of an Asherman's here when it is a very thin endometrium. A cystic hyperplasia can be present at cystic spaces inside the endometrial thickness. You where there is a role for doing a diagnostic hysteroscopy and many other conditions in infertility where we can do hysteroscopy. So a hysteroscopy done for an endometrial hyperplasia, where here you can see here, uh, we can see lots of changes in the endometrium inside the uterine cavity, so that you can see here it is more ragged, and we can take specific biopsies in some situations so that a blind dilatation and curettage can be avoided in this situation. So a see and treat policy is very, very good in hysteroscopic technique. So that is what is recommended. So intrauterine adhesions can be manifested as a very thin endometrium, or by clinically patient can present with a scanty menstruation, where many of the times we find in HSG an irregular pockets which are seen inside the hysteroscopy, and the hysteroscopy is a method of choice in these situations where we can see uh, uh, intrauterine adhesions, and these are also very common after a dilatation curettage or a vigorous curettage following a medical termination of pregnancy, or in a recurrent uh, curettage which is done for repeated MTPs. So here you can see an adhesions which is connected from the anterior wall to the posterior wall, where these intrauterine adhesions, which can be easily diagnosed and treated immediately at the same sitting by the hysteroscopy. So myomas are the other common conditions which can be associated with infertility as well as in recurrent pregnancy loss. And we know that almost 5 to 10% of infertile patients are the cause for infertility, and these situations hysteroscopy is useful, especially in type 0 where the leiomyoma are entirely located inside the cavity, or in some situation maybe in type 1 where less than 50% is inside the endometrial cavity. In this situation, hysteroscopy is the method of choice rather than doing an open or laparoscopic route. But a bigger myoma, more than say 3 or 4 centimeter, there is a long surgical time, and because of which the hysteroscopy becomes much more difficult. So the newer era is to have also using morcellation inside the uterine cavity, and now it is gaining importance. But a lot of still people are getting used to it with regards to different difficulty which they are still facing with regarding to the clarity inside the visuality inside the uterine cavity. But the newer morcellations are more promising, which are coming in the market. So a submucous fibroid is other indication for the hysteroscopy. Mullerian anomalies like in situation like septate uterus, or in situation when there is a uh, uh, other T-shaped uterus are also uh, some of the indication for either doing uh, septal resection or lateral metroplasty, if, depending upon uh, the 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 uh, so these are some of the situations where we use for doing hysteroscopy in infertility patients. I think just want to highlight uh, one more condition, that is the proximal tubal block in infertility, where the hysteroscopy is useful, where to open up the proximal the tube by tubal cannulation using an hysteroscopy, and that I think Madam Madhuri is also showing, especially when we do an hysterosalpingogram, we find like this cornual blocks. So we pass a guide wire through this hysteroscopy through the cornua, and we see from the laparoscope, and we open up this corneal block. So that is another indications where we can use uh, hysteroscope. So what are the contraindications? So the contraindication, the absolute contraindications are mainly acute pelvic infection or a vaginal infection, including genital herpes, pregnancy, or a recent uterine perforation, advanced uterine cancers, because the cancer cells can disseminate into the peritoneal cavity, pushing these cancer cells from the fallopian tube to the peritoneal cavity, increasing the staging of the disease. That's why they are absolute contraindications. The relative contraindications are mainly when there is an active bleeding. The visualization of the hysteroscopy becomes difficult. In this situation, they are absolutely, we should avoid doing hysteroscopy. As madam asked me to put a slide on how do you manage after the usage of the hysteroscopy instrument, how do you clean them? So important is, once you finish using the hysteroscopy, you first want to disassemble all whatever you have connected, what was shown. You run under a tap water as a normal lukewarm, rinse this hysteroscope and remove all the blood and surgical debris attached to outside of the instrument, the hysteroscope, the sheaths. And the lumen of the hysteroscope, the sheath, requires to be also cleaned. Either if you have a water pistol or you take a 20 ml syringe, fill it up and push with the force so that whatever inside the blood inside is removed. Then you require to place this in a tray with the enzyme solution. If you don't get enzyme, even hydrogen peroxide is good enough. You have to soak that for at least 5 to 10 minutes. And after that, you clean it with a detergent solution. Again, wash it with the water, dry it. That is very important. You have to dry, remove all the water content, and then you require to place it inside. So all this require to be seen very clearly. There is no water content remaining. Otherwise, there is a higher chance of it getting. So if you, at the end of it, if you're seeing any blood particle, you require to do all this thing again so that everything is clean at the end of. So you get this kind of brushes which is available depending upon the size of the lumen. You can use this and clean it. And also we have this remover where we can use this. You have to be careful while you are cleaning the eyepiece, otherwise you might land up in putting scratch on the eyepiece. So you have to be very careful using the optical surface of the telescope. So what are the things which are coming newer on our way? That is a mini resectoscope. There are intrauterine morcellators. Now the new one is True Clear. That is a 5 mm hysteroscope. Earlier, the True Clear is to come for a 26 French, that is 9 mm. Now the newer ones are coming for 5 mm. There are laser resectoscopes which are coming up. And there are new endometrial ablation devices which are coming up. So many new instruments are on the way for our day-to-day practice. So thank you very much for giving me this opportunity, and thank you for patient hearing.
Madam, please unmute yourself.
Hello, am I audible?
Yeah.
Yes, ma'am.
Hello, thank you so much, doctor.
Thank you very
Thank
much.
you so much, Dr. Rajesh Bhakta. You have very methodically and simply explained each and every aspect of indication, instrumentation, and contraindications. So we should know hysteroscopy is a very important procedure and very simple procedure. Everybody should learn and do it because it is very helpful. It is a see and treat policy is very, very important to adopt. Even the vaginoscopic approach is very useful. And if we can start the office hysteroscopy, so the acceptance and the morbidity is reduced. Thank you so much, sir.
Thank you very much.
Any questions?
Right now, no questions are there. I think sir has explained very well.
Yeah. Everything is methodically explained.
Yes. Thank you so much, Rajesh sir, for such an elaborative talk, because you have covered all the basic things, and really somehow every person stuck somewhere, and you have really taken out all the points very clearly, that where you are stucking with even cleaning and all, you have explained very nicely. Thank you so much for such a nice talk, and thank you, Pragya ma'am, for chairing this session.
Thank you very much.
Madam, do you want to say something? Madam, please unmute yourself. No, madam, you have to unmute yourself. Yes, madam. Oh, no, it is muted again, madam. It is muted again.
Now,
Yes, ma'am. Yes, yes.
one question to Rajesh.
Yeah.
Sorry. One of the indications, Rajesh, just to say that visualization of the endocervical canal, and it is getting really more with the colposcopy. So use of colposcope and histoscope together. If we have a type 3 ischemic columnar junction, we can use our histoscope very well to evaluate the endocervical canal to see the upper limit of ischemic columnar junction. I just want to add that one. He has a very nice presentation, very elaborate with the scopes and all that. I must congratulate you that you have done really, really great hard work in preparing your talk. Thank you.
Thank you, madam. I think you are right in that, but in the colposcope, the magnification is quite large. But in a hysteroscope, the newer high definition hysteroscope, maybe we can, we can go near to that and we can see some of the magnification.
It's still,
It is
we should be
always,
evaluating our endocervical canal with our scope, whatever the scopes available at present.
thank you.
Thanks. Thank you.
So if no questions are there, thank you very much. All Dr. Anuradha Dang, Dr. Abba Singh is there listening, and all the Kaveri and thank you, Madam Chairperson, for giving me this opportunity. Thank you very much.
Thank you, sir. Now, I would like to go ahead with our second talk on techniques of hysteroscopy. Definitely, knowing is not enough. We must apply. Just wishing is not enough. We have to do it. We must to do it. So, every technique is very different and very unique. But if you are not mastering even a simple one, you cannot perform nicely. People gain success with simplest technique as well. So that is the thing. One need to learn a simple technique also, but it should be very perfect. Once you are mastering your simple technique also, you can achieve success. For this, we have chairperson for the second session, Dr. Poonam Bajaj. She is from Katni. Madam is consultant, obstetrician and gynecologist. And she has been founder president of Katni OBGY Society and ex-vice president of IMA Katni. Madam has been speaker in many CMEs and webinars, and she also interested in many camps as well. I have been invited with her for camps also, and I really personally know her that she is very fond of working and very hard working lady. Over to Dr. Bajaj ma'am.
Madam, please unmute yourself, madam.
Hello, am I audible now?
Yes,
Hello.
ma'am.
Thank you, Dr. Kaveri, for such nice words. Very good evening to all of you out there. First of all, I would like to thank Dr. Anuradha and Dr. Kaveri for making me a part of this wonderful session. And I'm also thankful to all the stalwarts of endoscopic committee and continuous education society. As we all have seen such a wonderful presentation by Dr. Rajesh Bhatta with instruments and all. Next comes the technique. As Dr. Kaveri said, technique is very important, whether it's a simple case or difficult cases. For all PGs who are going to start, they must know the technique. And for those who are already doing it, we do get stuck in difficult cases. How to do in sometimes the myoma is difficult or the septum we get stuck. For all this, we know the perfect technique, and for that, we today have with us Dr. Madhuri Vidya Shankar. Dr. Madhuri Vidya Shankar is consultant gynec and laparoscopic surgeon at Milan Fertility Center, Motherhood Hospital, Bangalore. She has performed more than 9,000 gynec endoscopic procedures. That's really amazing. And she has a special interest in fertility enhancing laparoscopic surgeries. And she has authored book on single port laparoscopic surgeries in gynecology with Dr. B. Ramesh. And also she has contributed many chapters on endometriosis to her credit. So with that introduction, I would like to invite Dr. Madhuri, not taking much time, for her presentation. Dr. Madhuri, it's all yours now.
Thank you, Poonam Madam. I thank Foxy Endoscopy Committee, Jabalpur OB-GYN Society, and Dr. B. Ramesh, my guide and my guru, for giving me this great opportunity on this occasion, wherein you have all decided to dispel the knowledge of hysteroscopy, especially to the PGs. So I'm very happy that the PGs are also here. Am I audible, ma'am?
Yes, you are.
Yes. Okay. Now, can I share my screen?
Yes, ma'am. Can I share my? Yes, ma'am. Yes, ma'am.
Just a minute. I'm just. Now is this screen shared?
First, you open your presentation because it's not visible to us. First, you open your PPT and then you just share and click on the option.
Am I audible? Hello.
Yes, ma'am. Hello. Yes, madam.
Am I heard?
Ma'am, you are not visible and not audible properly. Yeah, now you are visible, but we can't see any screen. You just share.
Now is the same? Ma'am, is the screen shared?
Ma'am, it's waiting. It's in waiting. If you can share the PPT with us, we will run it. Actually, your network is quite poor. Your voice is also breaking.
Dr. Kaveri, you can ask her to
Is
send
it seen now?
to you, the PPT to you, and she can present it on her phone if her laptop is not working properly.
Yeah.
Just a minute, ma'am. I'll just check.
Yes. Yes, ma'am. No, just yes, ma'am.
Is it shared?
Actually, if you can
Now?
stop sharing and first you just open your slide and then you share a screen, it will work properly. Or else you can send it to us. You can send your presentation in the group or to me directly.
No,
You first
they're actually full of videos. So
okay, just you open your presentation first, let it get in a small icon, and then you start sharing. And click on the application where your PPT is visible.
see
Down,
now,
madam,
now is this?
down you have opened, na? So you just touch in the down. Yes, ma'am.
Yeah. Is it seen now?
Ma'am, your screen is seen, but your PPT is not open, so it is not coming. Or just you minimize this screen so you can see your properly your PPT. Minimize it and you just see down you have your PPT.
सब सुन रहे हो तो होल्ड कर लो.
Yeah, now is it open?
No, madam, we can see the screen with various presentations. The topic that you want to present right now, you have to click on that so that only that one opens. Madam, do you want the technical person to ring you up? And
yeah, please.
till
ले लो अभी तुम लोग लेते
till
हो
हेलो चिंतन जी, हेलो चिंतन जी, कुछ इसमें करो, मैडम का वो पीपीटी
Ma'am?
ओपन नहीं हो रहा है.
Yeah, it's visible now.
It's
Please
open.
make it full screen. You can start.
Yeah. Is it seen now?
Yes, ma'am.
तो सही कोई आ रही है क्या?
See,
Yeah,
ma'am.
is it? Huh?
It's running properly. You just start with your presentation, ma'am.
All right. So I'm very sorry for this technical glitch, or perhaps I was not able to do it. Now coming to the technique of hysteroscopy. So as Dr. Rajesh has explained it extremely well, now it becomes very to rush through to the technique. Now I'll be covering it as a diagnostic hysteroscopy, how to do a diagnostic hysteroscopy, how you could do an operative hysteroscopy, and then office hysteroscopy. Now a successful hysteroscopy will happen only when you have a good patient selection, you select the patient correctly, you have an experienced operator, and you have appropriate clinic and proper communication. The quality and the choice of the instruments and characteristics of the distension medium is well operator. First and foremost that we do when we plan the hysteroscopy is, after you have convinced the patient, a detailed consent form. Consent form is taken. Now the consent doesn't mean that you ask your nurse or the postgraduate to just take a signature on the consent sheet. You know, the informed consent will include three things. That is, the patient should be able to take a decision, that is decision making capacity, and all the risks should be disclosed depending on how the patient is and what the condition is. And then the patient should understand what procedure is being done and choose the procedure that you're offering or the alternatives that you're giving. So this is the format of our the detailed hysteroscopy. And we completely list the risks and complications like the bleeding, perforation, infection, and all other things. And then once the patient understands this, we advise them the preoperative preparation. Now, what exactly happens in preoperative preparation? One is you choose the date for surgery. So how do you choose a date for surgery? Now, this hysteroscope is best done in the proliferative phase when you are doing it for infertility patients. Proliferative phase because the endometrium is thin, the glands are not very dilated, and if any procedure is required, like if there is a polyp, there is a fibroid, or any other intervention is required, you'll be able to do it best in the proliferative phase with minimum blood loss. And then there are some cases wherein you could choose even the secretory phase, like endometrial plowing, wherein you would have given, I will explain what this plowing means. You would have given HRT for say around 3 weeks, and right around the time of implantation, you do this procedure so as to check how exactly the cavity is during the implantation time, and also do the plowing technique. And in evaluation of abnormal uterine bleeding, you of course do it anytime the patient has excessive bleeding, or you could do it again in proliferative phase. Now, once you have decided this, what are the pre-medications that you are going to give? Normally, in cases of infertility, we do not prefer to give any cytolog, that is misoprostol, to dilate the cervix. This, we believe, is because it can cause vascular changes inside the endometrium, which may not help you to assess the endometrium properly. That is number one. Number two, it gives you a very easy, it will be very easy to do a hysteroscope, which we definitely do not want. You know, we are not just doing a hysteroscopy to see the inside of the uterus. You're also assessing the cervical canal, whether it is feasible for the endometrial, the embryo transfer to happen easily, or do you require an anesthesia during the procedure to do the procedure. So to assess all these things, it would be best if you don't give any pre-medication to dilate the cervix. Now, these being the two important things, we take the patient for procedure. And do you do it with anesthesia, without anesthesia? Of course, in case of office hysteroscopies, you do not give any routine antibiotics or anesthesia. Okay, but in case of the procedure where you anticipate some procedure like tubal cannulations or polyp removal or any other operative hysteroscopy requiring resectoscope or the operative bridge, we certainly give a dose of cefotaxime most commonly. And depending on what the findings are, especially if there is a finding of endometritis, we would definitely prefer giving a course of antibiotics, which I'll explain later. Now that's about the antibiotics. So what anesthesia do you prefer for hysteroscopy? Now this again depends on the time that you take and the amount of dilatation of cervix that you require. The cervix is dilated not more than 5 millimeters if you're using a 2.9 mm hysteroscope. And if you're using a resectoscope, which may go up to even 6 millimeters, 8 millimeters, so you definitely require anesthesia. So anesthesia for diagnostic procedures can be performed even with local paracervical block, or it can be even conscious sedation, or even when you're planning operative procedures, regional or general anesthesia, especially if you're combining it with laparoscopy as well. Now, high-risk patients wherein they are hypertensives, you are not very comfortable giving a IV sedation, we do many procedures with paracervical block. So we use around 2% of xylocaine, around 10 cc, inject it in location other than 3 o'clock and 9 o'clock position. And around 5-10 minutes later, we could do the hysteroscope. This not only helps in anesthesia, as well as it also helps in dilating the cervix to a little extent. So whenever there is a difficult hysteroscopy, we could also use this paracervical block. Now, conscious sedation could be used because the procedure lasts for hardly 5 to at the most 10 minutes or even 15 minutes if you want to do some procedure. So conscious sedation alone would be sufficient. But if you're planning a submucous resection or a resection of a large septum, then you may definitely require regional or general anesthesia. Position, as explained by Dr. Rajesh, it is a subelithotomy position. Now, the main crux of the position of the hysteroscopy technique is the entry. I think everybody who does a hysteroscopy know very well how difficult it is to enter the cervix. If not in all cases, at least few cases, it can be very difficult to enter. So if the basics of how the entry happens, and if you know how the 30-degree scope works, and if also you know how to reach the internal os, I think these three things will definitely help you in reaching the internal os and gaining an entry into the cavity. So
Madam, can you explain, because it is not audible that good.
okay, you're not hearing that?
No, ma'am.
No.
I'll tell you then. Now is this heard? Hello?
Yes, ma'am, you are audible.
Hello?
But your
Okay.
yes, ma'am.
So what is being basically shown here is how to assemble the diagnostic hysteroscope. So we have 2.9 mm scope and we have 4 mm hysteroscope. Now, with the advancements in the technology, 2.9 mm have been very easy to do diagnostic hysteroscopes. So we have gradually started changing from 2.9 mm scope to 4 mm scope. Now, how you actually assemble, I'll just show it here. The requirement for cervical dilatation or even anesthesia. Now this 2.9 mm scope, you can use it for office hysteroscope as well. Okay, so what I'm holding in my left hand, okay, this is a 2.9 mm hysteroscope with the outer sheath, which comes to around 4 millimeters. So total instrument, that is a single sheath, single flow instrument, comes to around 4 millimeters. 2.9 mm hysteroscope with outer sheath of 4 millimeters. Whereas if you use a 4 millimeter scope, it comes to 5 millimeters. Now, how do you assemble this? There are marks over the outer sheath and over the hysteroscope. The marks are in the form of line. If you can see it there are two lines. This is an adjustable knob. What is rotated just now is the adjustable knob. Okay, so this knob, the outer sheath and the hysteroscope have to come in a single line. Adjust it in a single line, rotate the knob, then it gets fixed. So now it is fixed. Okay, so when you have to open it, open that knob and then take it out. So this is how you clean it as well. So whenever you're cleaning it, totally dismantle it and then clean it thoroughly. Okay, so whenever there is difficulty visualizing with only a single channel hysteroscope, we use something called as outer sheath. Okay, so this with the outer sheath, now this becomes 5 millimeters. So a 2.9 hysteroscope with an inner sheath of 4 millimeters and an outer sheath of total 5 millimeters. Okay, so the advantage of this being you will get a wonderful vision inside because you have both inlet and outlet. The proximal one is always the inlet and the distal one is the outlet. So here you can see that there is a vent for the saline to come out. So this will give you very clear vision inside the uterine cavity. Hope that is clear. Am I audible?
Yes, ma'am.
Now this is a 4 mm scope. With the inner sheath, it becomes 5 mm. And if you use an outer sheath, it comes to around 7 millimeters. 7 millimeters, whenever you want a clear vision, you will have to definitely dilate the cervix, which we do not want in case of infertility patients. So it definitely makes a lot of difference using 2.9 hysteroscope and 4 mm hysteroscope. And it is also very easy to get trained with a 2.9 hysteroscope than 4 mm hysteroscope. Only disadvantage being is it's a little delicate one, so it has to be handled with care. And your team, if you teach them well, I think it goes a long way. So now that we know how to assemble it, what are the methods of uterine distension? Dr. Rajesh has explained it very well with pictures and images. So the first thing being the hydrostatic pressure, wherein all you have to do is hang a bag around 1 to 1.5 meters above the patient, which will give you an intrauterine pressure of around 70 to 100 millimeters of mercury. Now, what is the pressure that is required to distend the uterine cavity? When you distend it to around 70 millimeters of mercury, you can definitely have a good vision. And beyond 70 mm of mercury, the fluid can go into the tubes and into the peritoneal cavity. That is, the osteo also open up beyond 70. So the idea of doing office hysteroscopy is keep the fluid pressure, the intrauterine pressure, to less than 70 so that you don't open the ostia and you don't cause peritoneal irritation with the fluid that you're using. So there, the scope that you use is very small and the distension can easily be maintained at around 40 to 70 millimeters of mercury, and you could achieve the procedure that you require. Here again, the pressure that is required will depend on the thickness of the myometrium, the kind of the procedure that you're planning, and also the lesion that is happening. So difficult lesions may definitely require higher intramyometrial pressures, the intrauterine pressures. Now, this pressure cuff is something like a manual pressure gauge, wherein you have a meter running on that. When you press, when you go on pumping the pressure cuff, you will know how much of pressure is reached, and you could gauge it, you could adjust it accordingly. But the best thing would be constant pressure variable pump, flow pump, wherein you can adjust the amount of flow that can go inside, or even you can adjust even the intrauterine pressure. So the best thing would be if you can adjust the intrauterine pressure, because once you set it to around say 100 or say 90 and you have a good vision, you don't have to go above that level. You can accomplish your procedure with that level. Now, why we say around 80, 90 or 100 is don't go beyond the average blood pressure. Okay, because if you go beyond that, there can be a lot of absorption. Keeping the flow less will go a long way in preventing the absorption related complications. So for a smaller procedure, you definitely will not have to worry so much about the intrauterine pressure, but it becomes a habit when you keep on using this. So keep minimum pressure, say around 70 to 100. And in cases of operative procedures like myomectomy and septal resection, you have to definitely take care of the input and output. Now, before understanding how to do the hysteroscopy proper, you have to understand this model. So here, how to introduce the hysteroscope and how to negotiate the internal loss itself is a big deal. Why is it a big deal? You are going to use a 30-degree scope. Now, can you see this is a 30-degree scope? That means you have a beveled edge here. Can you see this? This is a beveled edge. Yeah. So this beveled edge, because of this, the rays of light, how it is going, you can see here. So if you hold it in this position, in the upper picture, the wrong method where I'm showing, if you hold it in this position, you will go hit the posterior wall. And here on this side, you can see that this happens when you're visualizing the whole of internal loss. Okay, these are the crypts, these lines are the crypts, and this central hole, what you can see is the internal loss. Complete or hand is this upward or downward. Best method, such a way you see internal 6 o'clock.
Ma'am, nothing is coming from your side.
I think there is network issue.
Yeah.
Dr. Madhuri, we cannot hear you. If there is, You have to unmute yourself. You are muted. Yeah, now you are muted.
Is it seen? Hands.
Dr. Madhuri, can you hear us?
Completely down. So the 12 o'clock position or
Dr. Madhuri, can you hear us?
I think Madhuri ma'am has poor net connection. May I request Poonam ma'am to conclude the session and we can switch over to the next one because it's getting late.
I think sure, Dr. Kaveri. I think there is some network and technical issues with Dr. Madhuri. So she could not complete her session, but I would like to thank her for being with us and bearing all the issues. Thank you, Dr. Madhuri. It's very unfortunate that we couldn't hear you properly. Maybe better luck next time. Thank you, Dr. Madhuri, once again. I think Dr. Kaveri, we should move on with other next speaker. She is back. Dr. Madhuri is back. Dr. Madhuri, you can please unmute yourself. Your mic is mute. Dr. Kaveri, you can take the decision whether to move on or. Hello.
Hello, Dr. Madhuri. Yeah. Dr. Madhuri, can you hear us? I think she has a problem. So we will give her a call later on. I think it's time to
move on.
The third session. Thank you, Dr. Poonam Bajaj, for being with us. And she was speaking very well.
Yeah. We were really excited to listen to her.
Yeah, just maybe, if she can join us after the third session, we would like to see the technique. Thank you, Dr. Madhuri. I'll just give you a call. Now, moving on to the third session. The chairperson for the third session, Dr. Vibha Gehlot, madam. May I please welcome Dr. Vibha Gehlot, madam. She's the senior consultant and a clinical director of Yathar Clinics, Jabalpur. She's had a certificate of advanced hysteroscopy and surgical skills from RCOG London 2009. She's an accredited colposcopist and trainer, BSCCP UK since 1997. She's a pioneer in outpatient hysteroscopy with vaginoscopy since 2004. And she's a great asset to our city. She is a master, you can say, in office hysteroscopy. We welcome you, madam, and please take over the session from here.
Thank you. Can you hear me? Can you hear me?
Yes, ma'am.
Yes, ma'am.
Yes, ma'am, you are audible.
Yeah, I really, first of all, I thank Anuradha, Kaveri, and the Foxy Endoscopy Committee for asking me to chair this session. I really welcome Dr. K. Subhash Manya, who is a dynamic person, MBBS, DGO, DMB, MNNS, Diploma in Gynec Endoscopic Surgery from Germany. A well-knowledge person. He's presently consultant gynec minimal access surgeon and DMB guide, previous hospital and baby memorial hospital, Calicut, Kerala. Zonal Coordinator to Foxy President 2020, Secretary to Karikar Society 2020, and Kerala Chapter IAGE. He is Managing Committee Member IAGE 2920, Foxy Mentor and Mentee Award 2019, and a member of Foxy Endoscopy Committee since 2015 to 2018. Organizing Secretary to National Liver IAG 2018. Organizing Joint Secretary to Yuva Foxy 2015 and published many papers to Indus journals and chapter in many books. He is actually going to tell us a very difficult part of this all histoscopy procedure, which is the distension media and fluid management. Anybody who has seen any single case of fluid overload will always be scared of that one. And I most welcome Dr. Subhash Mali to share with us his thoughts about and educate us on fluid management as far as yet simple procedure histoscopy, but can become very difficult in some cases. Thanks. I welcome you, Dr. Subhash Mali. Take over from us.
Thank you very much, Viva Madam Ji, for this wonderful vision. Thank you very much, Anuradha Madam and Kaveri Madam and Team Jabalpur for this wonderful opportunity. It's a great pleasure to talk after my teacher, Dr. Rajesh Bhatta and Dr. Madhuri. And we have all got very good memories. Sir used to come as a PG examiner, and I used to be a PG there. And we have had a lot of experience. You know, I was a long time, long away. Sir was in Manipal, and I was in Belgaum at that point of time. It's a pleasure to see you and hear your section. Now, coming on to my topic per se. And I bring warm greetings from Calicut. And I would also like to thank Jabalpur Society for this wonderful opportunity. Again, they have actually supported me very much, and I've been elected as the Foxy Endoscopy chairperson for the next 3 years. I would like to thank all the society presidents and secretaries for having reposed their faith on me, and I would like to do justice to this. Okay, thank you very much. Right. Coming down to, as you have rightly said, ma'am, regarding the distension media. Okay, the distension media, it is always, you know, I have actually divided my talk into certain few aspects where, you know, first I would like to look about the classification, and then, as Vibha Madam had rightly said, about the complication part of it. So we all know about the distension media. The classification is we have gas, where we were using carbon dioxide long time back. We can use liquid, like the high viscosity ones, like the dextrin 32% is gone. We have the low viscosity, which is the isoosmolar electrolyte containing, like the normal saline and ringer lactate. We also have the mannitol and non-electrolyte ones, like the hypomosmolar ones, with the glycine, sorbitol, and dextrose. For all our practical purposes in today's life, we always go only for a normal saline and glycine. Okay. Now we all know about the uterine distension media. The reason is uterine cavity is a potential space, right? And we need a minimum pressure of 30 millimeters to separate the uterine wall. Initial talk and part of my talk will be slightly dry, but then at least we have to understand the basics, you know, before we go to the advanced ones. Okay. So let us understand that we need a minimum of 30 millimeters of mercury to separate the uterine walls, and we need about 45 to 80 millimeters of mercury to expand the uterine cavity. When you go more than 100 millimeters, it's rarely required. Though there are a lot of advocates who would say that pressure doesn't matter much. I think for all practical purposes, pressure is very, very important. Let us not be carried away by a few great surgeons who can do wonderful work. I think for basic, we have to stick on to what has been said over here. Okay. Now, the ideal flow rate is about 40 to 50 millimeters, ml per minute, and maximum should not exceed more than 100 ml per minute. This is very important to understand that. We always say push, 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 push. Not much of push, push in this. You have to be very careful. Okay. Now, the distension media, the complications which are produced by the distension media are specific to hysteroscopic surgery, because in lab we do not have these things. So it is essential that all the operating room staff should know about the side effects of the distension media. I always make it a point to tell the ward boy and the attendant, the staff nurse, and everybody. I always tell them what is the case and what exactly I would be required. It's very important for them also to know about what are the health which is required. Now, the nature of complications usually depends on the type of distillation media which is used. Now, carbon dioxide, I'm saying a bit about carbon dioxide because this is for the historical purpose. We rarely use it now. It was used in the case of diagnostic hysteroscopy in both diagnostic and operative ones. And the fluid usually can be of high or the low molecular weight. Now, this is a very important slide here. Understand this aspect. No? The normal saline, the normal osmolarity is about 285 milliosmoles per liter. And as we all know, it's an isosmolar one. The energy which can be used is the mechanical energy or the bipolar or the laser one. Okay. Whereas ringer lactate, the osmolarity is about 279. Glycine is about 200, but yes, it is hypoosmolar. Remember this aspect, glycine is hypoosmolar. Also dextrose and sorbitol is also the hypoosmolar ones. Now, carbon dioxide, I would not go much into that. Cardiac arrhythmia would occur with this. The hystroflator is something which I use. Never understand the aspect that you should not use the laproflator. Earlier, the people would be using the laparoscopic same CO2 scent, but it should not be used. Now, again, high molecular dextran, this is just for the sake of a completion. It can cause anaphylactic reaction. It can cause ARDS. It can cause pulmonary edema. So we do not use it much nowadays. Sorbitol again is not very useful. Okay, it is hypotonic. It is electrolyte-free sugar solution with 165 milliosmoles, but it can cause added hyperglycemia and hypocalcemia. So for these reasons, nowadays we do not use sorbitol because we have a better one. Now, electrolyte containing what we normally use are the normal saline and the ringer lactate solution. It can be used in diagnostic hysteroscopy, operative hysteroscopy, also using bipolar electrodes. So understand this. Normal saline when we use, you can always go for a bipolar spectroscope. But if using a monopolar, then glycine has to be used. Now, what does the European Society and the British Society have to say on this? They say that the management of fluid distillation media and operative hysteroscopy, you always use only normal saline, dextrose, or glycine. More often than not, in India, we are always interested in use. We are very commonly using normal saline and glycine. Okay. Now, glycine is about 1.5% glycine. It's a simple amino acid that is mixed with water and is supplied in 3 liters back as a 1.5% solution. It is a non-electrolyte containing one. It is hypoosmolar. It is non-hemolytic and it is non-immunogenic. So this is the advantages. Like dextran was immunogenic, so we were not using dextran, whereas glycine is a non-hemolytic and non-immunogenic. Non-hemolytic is very important because when you use glycine, you don't want your whole of system, to be filled with blood and you would not be able to see that. So that is a big problem with this. Now, the advantage of using a fluid media over a gas is it causes a symmetric distribution of the uterus with the fluid. Its ability to flush out the blood, mucus, bubbles, and small tissue fragments. So this is the most advantage because you want to see. It is not just see. You have to do see and do. It's not like the old DHC. It's like the see and do, where you see and you do, and you do not want blood, bubbles, or small tissue fragments in that. So that is why the advantage of using a fluid. Now, the pressure of 75 millimeters is actually adequate for uterine distillation. Beyond that, I will come back to that, the problems with this. And you can use both low viscosity and high viscosity media, which can be used for this. Okay. Now, again, as I said, the advantage is this. The second is, should the mechanism be faulty and leakage of fluid occur, it will be immediately visible and the fluid can be instilled and recovered and can easily be measured. So even if there is a leakage, whereas with CO2, it is very difficult to know about the leakage. With a fluid, you would know about the leakage, and any leakage you can always take care of that. Okay. Now, fluid overload, as Vibha Madam had said, what is the definition of fluid overload? Right? A fluid overload, the definition is, okay, you have a deficit of more than 1000 ml should be used as a threshold to define fluid overload when you're using a hypotonic solution in a healthy woman of reproductive age group. Which in turn is, if you're using something like a glycine, your deficit should not be more than 1000 ml in a reproductive age group lady, which is more important. Catch is the healthy lady. Okay. Now, a fluid deficit of 2.5 liters should be used as a threshold to define fluid overload when using a isotonic solution like a normal saline. Make no mistake, it is not something with hard and fast. I'll come back to the intricacies of this, but for all practical purposes, 1 liter of fluid overload in glycine and 2.5 liters in normal saline is the usual cutoff in a healthy lady. Okay. Now, how does this fluid absorption occur? Now, this is a very important slide where you understand about this. It occurs when you have an increased pressure. When the pressure increases, it is retrograde through the tubes. Okay. Now, when you have an endometrium, it goes through the endometrium. As Dr. Madhuri and Dr. Rajesh sir had said, you always do your surgery more on the proliferative phase and not on the secretory phase. And when you do a myomectomy, as the previous speakers would have shown you, when you use a myomectomy, what happens is you open up the vessels and sinuses and they actually absorb a lot of fluid. So this is how the fluid absorption occurs. Now, when it occurs is, as I have rightly said, and I've been specifying, saying, when you have a high intrauterine pressure, more than 75 millimeters of mercury, the fluid does, the tubular ostia opens up more than 75, and there is a retrograde flow. When you have a low mean arterial pressure, again, that again causes a fluid overload. Now, depth of myometrial and endometrial penetration during myomectomy, the TCRE and metroplasty. Now, that is the area when you have a larger uterine surface which has been operated, then you have a lot of fluid absorption. The most important is the duration of surgery. When you have a surgery for more than a particular amount of time, then your absorption is definitely going to increase, and the size of the uterine cavity. Larger the surface, more is the absorption. I think this is very clear why and how it occurs. Now, what are the factors which predispose to fluid absorption? Now, surgeons should always understand the factors that I said: the high uterine pressure, the low mean arterial pressure, deep penetration, prolonged surgery, and the larger cavity. Whatever I've shown in the previous slide, the same thing which I've put again. Now, low molecular weight fluids. Now, the problem with this is you have to have an idea about how much is the input and the output. It is always mandatory to know what is the input and what is the output. And the severity and management of fluid overload depends on the nature of medium. Again, needless to say, dextran or glycine is more dangerous than isotonic. When I say dextran and glycine is more dangerous than a normal saline, make no mistake to feel that if you use a normal saline, you're very comfortable. You don't have to worry about anything. No, you have to worry about everything in this aspect. Now, various delivery systems to accurately record the volumes of inflow and outflow. We all have a newer systems from the stores, from every company where you have a delivery system. The air should be flushed out from all hysteroscopic tubings before distension. Make no mistake, this is the most important cause of a small gas embolism or an air embolism. When you start an hysteroscope, always ask your assistant to open the tubes, leave out all the fluid, make sure there are no air bubbles. Now, air bubbles are very dangerous, because this can always cause your embolism. So remove all the air bubbles and only then you go inside and tube. Now, pressure cuffs on low viscosity fluid bags can be used for short procedures. I am not an advocate for saying that you can also use a pressure bag, but yes, there are many times when we would not be having, many of us do not have it. I'm sure not more than 10% of endoscopies in India would be having a various delivery system. But again, when you're using a pressure cuff, you should always be careful that you use only for a short duration. And pressure should be very minimal. I keep saying this to my postgraduates and everybody who comes for training with me. If you're able to see everything very clearly, that means your pressures are high. So always under pressure, if you're not able to see properly, that's also fine. But if you're able to really see properly, that means that the pressure is higher. Okay. Now, coming down to the complications per se, overload with glycine. This is very important. It can, in smaller doses, it can cause nausea, it can cause vertigo. The most important side effect or the problem which we have with glycine is the hyponatremia. It can cause a transient hypertension followed by hypotension, with the patient being disoriented and confused. Now, very excessive load may cause increased ammonium levels, leading on to encephalopathy. Now, if excessive amount of fluids are absorbed, hyperammonia, hypervolemic, hypoosmolar hyponatremia, or a central pontine myelinosis can occur. The most common that we see is a hypoosmolar hyponatremia. Now, understand again this particular thing, osmolarity of the fluids. Now, how is the severity of the complication depends on the fluid that you use. When you use a hypotonic solution like glycine, it can cause neurological problems like hyponatremia, cerebral edema, neurological impairment and seizures, and also cardiovascular failure. Whereas when you use isotonic, it is more of a cardiovascular effect. That means it goes more for cases of your left ventricular failure or a congestive cardiac failure. Whereas with hypotonic solution, it can cause neurological abnormality also. Menopausal status, very, very important. Remember that premenopausal, there is a higher risk of neurological complication due to the suppressive effect of estrogen on ATPase. So that is why use glycine in the premenopausal lady, always be under that caution. Now, cardiovascular renal status, irrespective of what I say, you always have to know that, you have to remember that if it's a cardiovascular renal case, you have to be very, very careful about this. Now, let us see how the glycine complications occur. Now, when the serum sodium goes in the level of 135 to 142, which is a normal sodium, no problem. But when you go in the range of 130 to 135, that is mild hyponatremia, it can cause apprehension, disorientation, nausea, vomiting, irritability, and shortness of breath. The moment you're using a glycine, and if you're doing it under spinal anesthesia, and the patient's blabbers, some sort of, discordant work, remember the first thing that should come in your mind is the hyponatremia. Okay, mild variant. If you're in the range of 125 to 130, then the urine is dilute, and the moist skin, pitting edema, polyuria, and the pulmonary edema can occur. More than 120 is a very dangerous situation where you have severe hyponatremia. It can cause encephalopathy, congestive heart failure, lethargy, confusion, and also death. And less than 125, the mortality is up to about 85%. Now, this is very important sign. It is called as the parotid area sign. Remember this: when you have a fluid overload, you can always see that this is the first sign you develop is the parotid sign. Okay, this is a sign of reflection of the interstitial edema that develops as a result of fluid overload. There was a significant increase in the measured philtrum mastoid prominence distance when fluid absorption was 1000 ml and above. So when you have fluid absorption more than 1000, you can see the philtrum mastoid prominence distance that is always increased. Okay. When the fluid absorption is equal to or more than 1000 ml, for every 500 ml increase in absorption, there is an approximately 0.5 centimeters increase in the philtrum mastoid prominence distance. And when it is more than 1.5 liters, and more than about 2 liters, the distance is about more than 1 centimeters. So always keep it in mind that this is a very good idea to know about the fluid overload. Okay. Now, the next is the saline overload. Now, this causes a simple hypervolemic state which may be treated by insertion of a CVP, administration of a diuretic, oxygen, and if necessary, a cardiac stimulant. Okay. Now, saline overload, as I rightly said, is something like similar to a congestive cardiac failure where you have increased amount of fluid in the body. When you insert a CVP, administer a diuretic and oxygen. If your patient is in cardiac failure, in case you can go for a cardiac stimulant. A blood pressure cuff may be applied to each limb to occlude the venous return, which in turn performs a bloodless phlebotomy and usually occurs in the immediate post-operative period. And the most important is you abandon the surgery. You do not proceed with these things when you have these problems. You immediately abandon this. Okay. Now this is how it says that a fluid overload, as I've said, more than 1000 ml when using hypertonic solution is reproductive age group, and 2000 ml is isomethylene is what is the recommendations. But when you have patients with cardiac and renal issues, your threshold should come down, and for an isotonic solution, your volume should not be more than 1.5 liters. So normal, as I've said, is more than 1 liter for glycine and 2.5 liters for normal saline. But when you have a cardiac patient or a renal patient, the levels should not be more than 750 ml for your glycine and 1.5 liters for saline. Okay. Remember these things. Closed systems are more helpful for accurate fluid output. Use drapes that have a reservoir, something like the brass key drape that we use for PPH. Automatic fluid management is always better. And we have one member who would always like to see, what are the returns. In my cases, after the case, what I do, I myself take out a mug, check out for the fluid deficit, and I always am very skeptical of that. I do it myself. I have an idea about this. Hyponatremia, I did say about this. Fluid overload, again, I have said about this. Now, the amount of fluid, again, I did say about this. Now, complications should always, be recognized early. Now, symptoms should be timely recognized and treated. Strict fluid balance monitoring should be done once the serum fluids are measured. If the patient has signs of cardiac failure, pulmonary edema, an echo and an X-ray should be taken. And initial treatment with a 3% hypertonic sodium solution should indicate to restore the serum sodium concentration. Always when I tell all my postgraduates or my residents are, when you use a normal glycine, I always said do not put the patient on a dextrose containing fluid, because dextrose containing fluid like a DNS or a 5D in your post-op orders is going to aggravate the hyponatremia. So do not write a dextrose containing fluid. Always give an isotonic like a normal cement and try to restrict the amount of fluid when you use a glycine. Okay. Now, what are the pre-operative? Now, I've said about the fluid overload. What can be done in the pre-operative period? A strategies is pre-operative administration of GnRH agonist in cases when you are going for a hysteroscopic resection of fibroids. Again, intracervical injection of dilute vasopressin should be considered before dilatation of cervix. Now, these are the measures pre-operatively. Now, again, The preoperative, I think the methods to deliver the distribution media is very important. Now, delivery of the distribution media can be safely and effectively achieved using simple gravity, pressure bags, and automatic delivery system. Automatic delivery system is always better for an advanced case like a myomectomy or a TCRA because you have an idea about the backbone. Now, intraoperative measures, I've spoken about the preoperative. Now, the intraoperative ones are the intraoperative pressure in for distance should be maintained as low as possible to allow adequate visualization and kept below the mean arterial pressure. So when your pressure increases above the mean arterial pressure, that is when the absorption is going to increase. Okay. Now, these are the other ones again I said. Now, prevention of the overload can be done as I've said. Same thing again. Okay. Now remember this in a very easy algorithm. Now you have asymptomatic hyponatremia and the sodium levels are more than 120. You restrict the fluid more less than 1 liter per day, and you give a loop diuretic like a furosemide, which is inevitable. Now you have a symptomatic hyponatremia or the sodiums are less than 120. You give hypertonic saline. Okay. You give an oxygen, you put the patient on catheter, and you have to have a multidisciplinary approach in these patients. Okay, right. Now, this is very important. This is a very important slide which we always maintain. You see this fluid input, fluid output, and the fluid balance. You see this at 10 minutes, 20 minutes, and 30 minutes. Okay. Now, if not likely to complete the process under 60 minutes, then you stop. If you're not comfortable, stop and go for a second case. But again, do consider that if you're going for a prolonged surgery, it's always advisable to go for a 2 sitting. Okay. Now, the recommendations and conclusion are based on when you use a electrosurgical procedure with monopolar instrument, it is always we use a mannitol, glycine, or a sorbitol. Okay. Now, hysteroscopic myomectomy, very important. We use a monopolar, bipolar, or plasma in these cases. Now, to decrease the problems with this, all this fluid overload usually comes down with 2 surgeries. That is with the myomectomy and one with the TCRE. So this is something at trochlear system where you use a Smith and Levy system where you use a hysteroscopic morcellator where you do not use any current, you use only a. You can see over here, you can see here. Now, take home messages from this particular talk is use the appropriate distribution media and the delivery system. You keep your operating time to minimum. Avoid entering the vascular channels. The moment you have a vascular channel, about that, keep the fluid pressures less than 80 milliliters of mercury and the gas pressure less than 100. You have to have a meticulous account of the fluid balance, as I've said. Take care, just have an idea of how much is fluid. You do it yourself, okay? And the procedure should be abandoned if the deficit rises to 2 liters and there is evidence of venous congestion. Now, before you go out for these surgeries, okay, or you can always go something like this, where you can see this, this is a symbiotic system where you have an adequate idea about this. So you have an adequate training about these cases, in a virtual system before you go for the cases. You can see here, this always helps us. Of course, a virtual is virtual and a real is real. As you can see right side, you can see there are a lot of air bubbles. So can you tell me which is the fluid that's being used here? You see a lot of air bubbles in this case. Okay, you remember that when you see an air bubble, a lot of air bubbles in this, it's more commonly that we use a normal saline. Okay, when you use a normal saline, the difference between using a normal saline and a glycine is with the glycine, there'll not be much of air bubbles. When you use a normal saline, you have a lot of air bubbles with this. Okay, so I've just kept it concise. I've just kept it very, very minimal because I do not want, because since it's the case of basics, I do not want to scare everybody, Hearing to the complication cases, nobody should stop doing hysteroscopy. So I've kept it very minimal. I've just scared them enough, to be scared and not beyond that. Thank you very much, Poonam Madam. Thank you very much, Vibha Madam. Thank you very much, Team Jabalpur. And thank you very much, Madhuri and the team for, taking this wonderful opportunity. Thank you very much.
Thank you, Dr. Subhash. A very wonderful presentation of a very difficult chapter or difficult term on fluid management. Very, very nicely explained what we have to do. I think I saw one line, accountancy, and that is what the most important thing in fluid management, which you have elaborated very nicely. I will say that when I was a junior, my consultant used to say to me that you should be knowing your patient inside out You should be knowing your instrument, what you are using inside out, and you should be knowing your consultant inside out. And when I became consultant, we used to say that you should be knowing your patient inside out. You should be knowing your team inside out. Who is dealing with what? And in hysteroscopic surgery, one must delegate one person to know the fluid and tell us, because we get so much engrossed, we don't know the time we have spent in surgery. And as you said, time is most important factor in fluid overload. And third thing, the rest here, your anesthetist. Somebody must inform that you are going above your time or your limit. Thanks very much. Such a really beautiful talk by Dr. Subhash Malla. I thank on behalf of our Jabalpur Society, and I will hand over to Dr. Anuradha to do the rest. Thanks.
Nice
Thank you.
presentation, Dr. Subhash. Nice presentation by you. Yeah. You very nicely told what things and to do and how to manage the fluid, because people think that once they introduce the scope, their job is over. But no, you have to manage this fluid balance also. So that is one of the basic steps which you have elaborated very nicely. Hello. Hello.
I think, ma'am, Dr. Subhash has lost his connection.
Okay, no problem. At least it was a nice session. Yes. So I would like to thank everybody.
I think we all were ready with our questions and suddenly he vanished. It appeared. No, actually, ma'am, he was just doing something and suddenly his connection lost. Now, may we ask question meanwhile to Dr. Rajesh? The same question, madam is. Abba, ma'am, can you repeat your question so we can ask to
No, I did
senior?
not get any question. It was just a remark, comment.
Okay, I have actually question.
Yeah.
If we are already using a normal saline just for diagnostic hysteroscopy and we suddenly encounter one polyp or something, then how to plan for the operative immediately if we don't have cold night and we only have some electrical instrument only, then how to switch means what should be the ideal plan for that?
Subhash, you want to answer or shall I answer?
Please, sir.
No, it's a very simple that you require to keep a glycine ready. And once the glycine is ready and you require to remove the connection of the normal saline, flow the glycine for some at least about 15-25 ml, and then you connect and start using monopolar current. So that is what you require to do. You always in a OT setup, you will be always ready with your both for glycine as well as normal saline. And for diagnostic purpose, it's always better to use a saline, so it will become cost effective also. Only use whenever you require glycine.
So once it is flowing, we can switch off that connection. We can shift our connection. Is it like that?
Yes,
Okay.
you just require to change the glycine, and the same tubing can be used and connected to the other, or you can use a separate this one. Doesn't matter. So only thing is, if you are using the same tubing, if you require to flow that glycine for some time, so that you can use. Otherwise, your saline monopolar current won't work. So that's why you require to use glycine the same tube. So that's what it is.
I want to say maybe few people may be thinking why such kind of question, because what happens when you are working in low resource setting and the cost is coming in your work, then such things happen that kya kare now, what is the second option we can do? That actually happens. So that's why my question was, because sometimes we encounter like that, and we immediately we are unable to shift for higher setting.
Yeah.
So
The problem doesn't come for a polyp. The problem doesn't come for a simple polyp where you can use a scissors. The problem comes while you are using for a submucous fiber. Scissor won't work. You require to use a monopolar. The other option is while you are buying, you can buy a bipolar resectoscope. In that, you
Dr.
don't
Rajesh,
require to use.
life will become easy if we have bipolar. It's very easy.
No.
Now we have
Those,
started using bipolar and we are at peace.
no, actually, people who are buying new will think about it. People who are already having monopolar will continue using a monopolar. And whenever you are using monopolar, you have to have a glycine with you. And the idea here is your selection is important. Otherwise, you require to follow all what Subhash said. The whole chart required to be followed. The whole team should be good enough. You have to have an outflow fluid measurement, and you require to know how much amount of fluid is gone inside the cavity. I think Subhash explained very well, and you require to follow all those things, especially if you go your surgery goes beyond a particular time, so you have to be careful.
What I want to add anything.
I didn't get, madam, anything.
I want to add something to that. When we are encountering, say, we are doing just a diagnostic one. If you are using, say, Hawkins, simple Hawkins, where you don't have any channel, there is a problem. But if you are using any histoscope with a small secondary channel to introduce any scissors or any crocodile forceps, just take out a small polyp cavity, no problem when you are doing in a low set, low resource settings. If it is really needs a resection, then you have to stop the procedure, bring the patient to the second setting. No way out that you can use a diagnostic histoscopy converting into a therapeutic histoscopy is a difficult thing. The small polyps, 1 to 2 centimeters, is no problem. Just fleshy zero type polyp in the cavity is no problem whatsoever. Even if you will leave a little stock, no problem. This is a benign thing. Just send whatever you have taken out for histology, leave it as such, it will work. That is my experiences.
Very well said, madam. That is absolutely right. That anything mucus polyp and other things can be managed without any problem. But when it comes to the fibroid,
Yes, when it comes to therapy,
connection is okay, then may I request Dr. Madhuri ma'am to go ahead with her remaining presentation, because we were really into it, and we just because of poor connectivity,
Dr.
we just missed the
Subhash
maximum
is back.
portion.
Yeah, I'm really sorry. I went off at the wrong time and I had some problem with the connection.
No, definitely you are in now. Please. We are thankful to Dr. Vibha Gehlot madam. She is a very senior gynecologist in our place, and she is one of the person who is regular in hysteroscopy and all. So thank you, ma'am, for chairing this wonderful session.
Thank you very much, Vibha ma'am.
Thank you, Dr. Subhash. Your questions we have dealt with Dr. Bhatta sir.
Bhatta sir, thank you very much for saving my day.
Thank you so much, Dr. Sir. Thank you. Thanks very much.
Thank you, ma'am.
Next 3 years, we will really touch you for your services. We hope this COVID will go and you just come to our place, Jabalpur, because we do all workshops on endoscopy and all. Dr. Pragya madam, she regularly makes these things happen in her place. So Jabalpur Society will be very much thankful once you come and join here.
I would request Pragya madam, please give us an opportunity, Pragya madam. आप बुला लेंगे, हम भाग के आ जाएंगे, मैं और भक्ता सर भाग के आ जाएंगे, माधुरी मैडम को भी पकड़ के.
Thank you so much, Dr. Shivaji. Thank you. Ma'am, Madhuri ma'am, please go ahead with your presentation. We really want to listen that. Thank you so much. Ma'am.
Again, I think the connection is lost.
Madam, in the meantime, ma'am, I just had one small, when Madam asked, ma'am, we need a diagnostic hysteroscopy and we have a polyp, ma'am. Ma'am, what are we have a lot of compatible machines, ma'am, which you can straight away go for a bipolar resectoscope, ma'am, which actually goes through a 5 French, ma'am, which goes through a 5 French one only. So it's like the same your diagnostic scope, and you can do a bipolar resection also, ma'am. You can, if you have a polyp, you just have to go like a monopolar needle. You have a bipolar needle, but you just cauterize the base and take out the polyp. So that is also available, but again, for that you would require that particular electrosurgical unit. And on a lighter side, you get that electrosurgical unit from 2 lakh rupees to 15 lakh rupees. So you have that electrosurgical, I mean, everything. You have your monopolar, you have your bipolar, you have a vessel sealer, and you have an underwater cutting. Everything is available from 2 lakhs to 15 lakhs. And it depends on your budget. Of course, you don't expect a 15 lakh quality in 5 lakh, I mean, 2 lakh machine.
But in our place, we have to really counsel for hysteroscopy itself, because people will run for hysterectomy rather than hysteroscopy. That is the problem, and then again we have to think why to buy. It happens like that. So that is the one reason behind it. But still, I dare to buy and I dare to start hysteroscopy, and I'm doing it. But still, it really takes too much of pain to counsel the patient that yes, you will achieve something after this procedure. Also, please save your uterus. That is the thing.
I think it is the best time to start office hysteroscopy. Very, very minimal amount of capital required.
But lot of counseling is required for that.
No,
it's like doing a transvaginal sonography, madam.
Hand over to Dr. Jigyasa. If Dr. Madhuri is not able to connect, then I think we'll come to the end of the session. Dr. Madhuri, can you hear us? I think she has
left. I think she has left.
She's left, no?
She's there.
She just left, I think. I just saw this thing.
Dr. Madhuri.
Hello, am I audible, ma'am?
Yes, you are. Yes, you are.
Yeah. Yeah. So I'll just show the procedure of hysteroscopy, how to basically make the hand movements. See, if it is an anteverted uterus, we usually keep the cable down. So this light cable.
Madam, you have to share the screen. Madam, you have to share the screen.
Oh, not shared, is it?
No, you're not shared. Please share it.
Just a second.
Yes, now you've shared it. Yeah, now you can see.
Yes. So this is the procedure of hysteroscopy, basically how to do the hand movements. Okay, so you're holding the hysteroscope with the head up. Okay, so what you can see here, and the light cable is placed upwards or downwards depending on whether it is the anteverted uterus or the retroverted uterus. Or you can simply keep it down, and once you enter the uterus, see, this is 3 movements I can say. First one, just keep it in the center. Okay. Now, once you move the whole thing to the left side, you'll be able to see one ostium there. And if it is not very clear, you can rotate the cable. You can see that the cable is being rotated to get the complete vision. Now get the whole scope to the center. You are seeing the fundus there. Okay. So fundus. Now once you see the fundus again, go to the opposite side. Okay. Take the whole set to the opposite side. Now if you're seeing the os fine, if not, rotate the cable again. Can you see? And this rotation of the cable will depend on whether you're seeing the right ostium or the left ostium. Since it is a 30-degree scope, to visualize the right ostium, you'll rotate the cable to the left. And to visualize the left ostium, you'll rotate the cable to the left. Basically, it is all opposite movements in hysteroscopy because it's a 30-degree scope. Now, what do you look for in case of hysteroscopy? Yes, you have achieved entering into the cavity, but what do you see? Now, basically, we are going to, this is the report that I'll highlight again at the end. But what I basically want to see is the whether it is
भी नहीं आई हम बोलेंगे तो उनको भी नहीं जाएगी पर ट्राई करें
So this is what you see. This is the hello.
Hello. Yes, madam. I think we are struggling with the network issue today. So the audio and the video is not very clear, madam. Is it? I think, Madhuri madam, if you please do not mind, I think we'll have a detailed session. Yeah. Okay. Can you hear us, madam?
Hello. Yeah, ma'am. Sure, ma'am.
We'll have a detailed session.
So major problem here. So probably I'm unable to connect.
We understand, Dr. Madhuri. No problems.
Sure.
Yeah.
Very sorry for the inconvenience.
Doesn't matter, Dr. Madhuri. We'll keep a detailed session with you the next time. Now, may I please request Dr. Jigyasa to offer vote of thanks?
Sure.
It is my privilege to take this opportunity on behalf of JOBS to thank all the experts of the field who took their time and have given us many tips and tricks to improve our skills. I'd like to thank Dr. Rajesh Bhakta sir, Dr. Madhuri Vidyashankar madam, Dr. Subhash Malia sir. I'd also like to thank Chairperson of Foxy Endoscopy Committee, Dr. B. Ramesh sir, and Dr. Abha Singh madam, Chairperson of Medical Education Committee, who gave us guidance for this series, and we are going successful till now. I also thank our guest of honor, Dr. Mandakini Meg madam and Dr. Parag Biniwala sir for granting us ICOG points for each of the part. I'll also like to thank our chairpersons who coordinated the sessions very well, Dr. Pragya Dhiravani madam, Dr. Poonam Bajaj madam, and Dr. Vibha Gehlot madam. I'd like to thank our President Anuradha Dang madam and Kaveri Shaw, our secretary, who had vision to clear our doubts about the keyhole surgery. And I thank all the members of Jabalpur of Gynaec Society and also all the postgraduates and participants who made our program successful. Thank you all.
So thank you very much. Bye-bye. Bye.
Thank you. Thank you, sir.
I'm also thankful to Nishiro for making this program successful one, and behind they are with us for making a very good technical support. I hope certificates are also uploaded. Is it so, Mr. Nitin? You are muted.
Not yet, but we can do it in the later on. Again, we will ask them to
Today actually
download.
we just got late for few of signatures, but from next time onwards, everybody can download their own certificates. Today's certificates we will be sending on emails, whichever you have logged in and you have registered. We have the list, and we got one ICOG credit point for every web series. So that is the good thing. The postgraduate and participants can take that opportunity to get the ICOG credit hours as well. I'm thankful Dr. Rajesh sir, Subhash, Dr. Subhash and Dr. Madhuri ma'am. And Madhuri ma'am, we really request you to join our further sessions as well, because once in any of the session, if we find time, we will really catch you for your your technique, or if possible, we will keep you in the next session in the first one, if possible. And I'm thankful to our so much experienced chairpersons to be with us, Dr. Poonam ma'am, Dr. Vibha madam, Dr. Pragya ma'am. Thank you so much. Thank you everyone for making the program a big, good start. Thank you so much, and thank you. Please join in next 3 sessions as well, and also circulate this web series invite to all your PGs as well, because it is, I hope, fruitful not only for us but also for PG students as well, because once they learn this technique properly with masters, they will do far better once they come into the practice. I hope they should also get this opportunity. Being in their own place, they can get a good quality knowledge from the web series as well. Thank you, everyone. Thank you so much.
Before you close, ma'am, I just have a very small request, ma'am. That ma'am, it has been a wonderful initiative by Team Jabalpur, ma'am. I'm very grateful to you, ma'am, because it's a wonderful initiative, ma'am. At least, frankly, ma'am, even I have learned a lot. Now I've learned some tricks from you, so at least know what I can do for the next years also, ma'am.
You just be with us. Thank you.
It's a wonderful idea, ma'am, because the problem is most of them, they're all so much engrossed in advanced one that no newer persons, would like. Now all the seniors or the mid-level practitioners, ma'am, they say nahi abhi nahi karne ka, bas ho gaya, abhi hamara humko jo bas. And only the younger crop is coming up. So what happens is with this basic, why I when in my talk or in Dr. Rajesh talk, all has been spoken about very basics, not just because a basic topic, but you can learn a lot of basics. I think that's where most of us do a mistake. Everybody wants to go for advanced. Nobody gives any importance to advanced. I keep saying this very often. I keep saying, you learn basics. You learn basics. That's what will help you in life. You don't learn advanced. It's okay. It doesn't matter much in life. And thank you very much, Team Nishiro, for this wonderful opportunity. Modi ji, thank you very much for
Thank you, sir. Thank you. It's our pleasure, sir.
Support. And I'm sure you will support us in all our future endeavors. So,
definitely.
In terms of education, not finance. So don't, in terms of education, we would always take a lot of help from you. Thank you, sir. Thank you very much, Kaveri madam. Thank you very much, Anuradha madam, and Team Jabalpur madam. Thank you very much.
Thank you.
Thank you. Thank you so much. So our purpose is solved, and we had a very good attendance, as Mr. Nitin Modi will share later on with us. And thank you for logging in with us and be with us for the next 3 subsequent sessions. Time to leave from Jabalpur.
Yeah.
Good night. Thank you.
Thank you, madam. Good night. Thank you.